Welcome to SurgiSmart Cut to the Core podcast for FRCS and MRCS preparation.
Glad to be here for this one.
You know, usually when we talk about a surgical diagnosis, there's this underlying expectation of anatomical precision.
Right, absolutely.
Like you're dealing with a perforated viscus, you see the free air under the diaphragm on the erect chest x-ray, and you just book the theater. The pathology is macroscopically obvious. You point and say, there's the problem, let's fix it.
Yeah, it's the comfort of the binary. I mean, the tissue is either ischemic or it's viable, the bone is fractured or it's intact. Surgeons are, inherently trained to seek out that definitive visual absolute before they ever make an operative plan.
Exactly. But the moment you step into the world of esophageal metaplasia, and specifically the cascade leading to esophageal adenocarcinoma, that comforting binary diagnostic landscape just completely disintegrates.
It really does. It vanishes.
You're no longer looking at gross anatomical failures. You are staring into this diagnostic and molecular void that is intensely murky, highly subjective, and honestly, completely unforgiving if you misinterpret the data.
Which is exactly what makes it one of the most perilous areas in upper gastrointestinal surgery. I mean, the margin for error isn't measured in centimeters of bowel anymore. It's measured in microscopic layers of cells and subtle genomic shifts that occur long before the patient ever feels a lump in their throat or struggles to swallow.
And that is exactly why we are dedicating this entire deep dive directly to you. We are talking to these senior surgical registrar, the PhD level candidate, the clinician who's burning the midnight oil, preparing for those higher FRCS exams.
We know your baseline.
Yeah, exactly. You already understand the gross anatomy of the foregut. You understand the basic physiology of digestion. We are absolutely not going to waste your time defining the lower esophageal sphincter or reviewing basic medical school histology.
No, instead, our mission today is to completely and brutally deconstruct Barrett esophagus. We are moving deep into the weeds here.
Well, we're
going to pull apart the advanced clinical literature, interrogate the precise molecular pathogenesis, and explore the incredibly complex histopathological dysplasia continuum, and of course, rigorously analyze the 2022 American College of Gastroenterology, the ACG guidelines for endoscopic eradication therapy.
Because before you can even begin to formulate a macroscopic surgical plan, before you ever even think about picking up a scalpel for an Ivor Lewis esophagectomy or deploying a submucosal dissecting knife, you have to intimately understand the molecular triggers initiating this premalignant condition.
You really do.
The macroscopic disease, that velvety salmon-colored mucosa you see on the high-definition endoscopy screen, is really just the final delayed echo of a microscopic cellular crisis that has been raging for years.
That is exactly the right perspective. The visual change is just the aftermath. The actual war is fought at the biochemical level.
Right.
And the precipitant for this war is a highly specific, continuous biochemical assault on a tissue that was just never designed to withstand it. We're talking about chronic, long-standing gastroesophageal reflux disease, but it's crucial we don't just view GERD as acid. It's a highly toxic, complex refluxate.
Okay, let's unpack this toxicity. So the gastric lining is a mucinous columnar epithelium, fundamentally architected to survive a pH of 1.5. Has that mucus bicarbonate barrier.
Yes, it's built for it.
But the esophagus, however, is a stratified squamous epithelium. It's built for mechanical, friction-like swallowing a poorly chewed piece of steak, not chemical warfare.
Exactly.
So when the lower esophageal sphincter chronically fails, you are constantly bathing that vulnerable squamous tissue in a mixture of hydrochloric acid, pepsin, and critically duodenal bile.
And the physiological response to that bathing isn't just a simple chemical burn. I mean, the squamous cells don't just passively die off.
They fight back.
They actively react. The continuous exposure to this low pH bile-rich irritant induces the squamous epithelial cells to mount a massive defense. They begin to actively synthesize and secrete specific pro-inflammatory cytokines.
Which ones specifically?
Well, the advanced literature pinpoints two primary molecular culprits driving this initial phase, interleukin-8 and interleukin-1b.
And this isn't just generic inflammation, right? IL-8 is a highly potent chemokine.
Oh, very potent.
The moment those distressed squamous cells release IL-8, it acts as a molecular homing beacon. It establishes a chemical gradient that signals neutrophils and T lymphocytes to migrate out of the microvasculature and directly infiltrate the esophageal epithelium. You are actively recruiting an immune army to the mucosa.
You are. But the problem is that this immune army causes immense collateral damage.
Friendly fire.
Exactly. The neutrophils arrive and they release reactive oxygen species, ROS. These oxygen-free radicals cause massive oxidative stress, which leads directly to double-strand DNA breaks in the replicating basal cells. But as you alluded to, the acid and the immune response are really only half the equation here. The bile acids present in the reflux phase, specifically unconjugated bile acids like deoxycholic acid. They play an even more insidious, highly specific role in altering the genetic destiny of the tissue.
Because at a highly acidic pH, those bile acids become non-ionized, right? And highly lipophilic.
Yes, precisely.
They literally just melt right through the lipid bilayer of the squamous cell membrane. And once they are inside the neutral cytoplasm of the cell, they reionize and become traps.
That's the trap.
And this is where the genetic reprogramming happens. The sources show that these intracellular bile acids directly upregulate CDX2.
And CDX2 is the master regulatory transcription factor for intestinal differentiation.
Normally found only in the gut.
Right. Normally, it should only be expressed in the gut, directing cells to become intestinal enterocytes and goblet cells. But here, the bile acids are forcing its expression in the esophagus.
That's wild.
And alongside CDX2, they upregulate MUC2, which is the exact genetic blueprint required to create a goblet cell.
So the bile acids are literally acting as rogue engineers. They're breaking into the command center of the squamous cell and forcibly rewriting its identity.
That's a great way to put it.
They're telling the tissue, the squamous blueprint is failing. Adopt the intestinal phenotype to survive this acid bath. It is an active, desperate reprogramming.
It is.
And in the chaos of this massive cellular turnover and oxidative stress from the neutrophils, the genetic mutations just begin to cascade. The data is staggering here. Up to 90% of affected patients harbor a detectable clonal aberration of the p16 tumor suppressor gene.
We really have to pause and consider the biological gravity of that 90% figure. I mean, P16 or CDKN2A is a fundamental brake pedal for the cell cycle.
Right. It stops things from getting out of control.
Exactly. Under normal conditions, P16 binds to CDK4 and CDK6, preventing them from phosphorylating the retinoblastoma protein. This keeps the cell securely locked in the G1 phase, preventing it from replicating if there is DNA damage.
But when you lose P16 through hypermethylation or mutation,
you cut the brake lines. The cells begin to divide uncontrollably in an environment that is just swimming in reactive oxygen species.
And as if losing the brakes wasn't bad enough, we also see the early loss of the primary safety net TP53 mutations. And the literature emphasizes that these CDX2 and TP53 mutations are occurring as incredibly early molecular alterations.
Very early.
Like they're detectable in the metaplastic columnar epithelium way, way before any pathologist can recognize morphologic dysplasia under a microscope.
It creates a fascinating and somewhat terrifying timeline, doesn't it? The genome is fundamentally breaking down long before the cellular architecture visually collapses.
Yeah, the invisible threat.
Which brings us to a massive, hotly debated controversy in surgical pathology. Where are these mutated, reprogrammed cells actually originating from? What is the cell of origin for Barrett esophagus?
It's one of the great biological mysteries of the foregut. You have two highly polarized theories. On one side, recent high-level studies point to a localized source.
Right, the resident theory.
Yeah, they describe this microscopic niche of residual embryonic stem cells located right at the squamocolumnar junction, the Z line. The theory proposes that the toxic reflux environment triggers these dormant embryonic cells to rapidly differentiate into the metaplastic columnar tissue.
So it's a localized resident cell theory. But the competing theory completely flips the entire paradigm of how we understand gastrointestinal healing.
Oh, this one is wild.
It is. There is compelling evidence suggesting a completely systemic response. This theory proposes that the true precursors are undifferentiated mesenchymal stem cells. Some hypothesize these reside in the lamina propria of the esophagus, but the more radical evidence suggests they are migrating all the way from the bone marrow.
Wait, so you're telling me that an acid burn in the distal esophagus sends a systemic distress signal that reaches the bone marrow, recruits mesenchymal stem cells into the peripheral circulation, and those cells physically migrate to the esophagus to engraft and form Barrett tissue?
That is exactly what the systemic theory proposes. It utilizes pathways like the SDF1-CXCR4 chemokine axis. The damaged esophagus releases stromal cell-derived factor 1, which acts as a homing signal for the CXCR4 receptors on the bone marrow stem cells. They arrive at the site of the injury, but because they are engrafting into a highly toxic, acidic, bile-rich environment, they don't differentiate into normal squamous cells.
They panic.
Basically, yeah. They aberrantly differentiate into columnar tissue.
Wow. Whether the origin is localized embryonic cells or recruited bone marrow stem cells, the sequence of visible mucosal transformation is generally agreed upon, right? The tissue doesn't just instantly become intestinal.
No, it transitions.
It likely begins as a cardiac-type or gastric-type mucinous epithelium, throwing up basic mucus as a primary defense. But then it goes through an intermediate phase to achieve full intestinal differentiation with goblet cells. The sources specifically detail this highly transient morphological state called the multi-layered epithelium.
Yes, the multi-layered epithelium, or MLE, is the literal microscopic missing link. Pathologists see a tissue that expresses combined squamous and columnar features simultaneously.
A hybrid.
Exactly. It is highly associated with active reflux esophagitis, and immunohistochemistry reveals a mucin and cytokeratin profile that is strikingly identical to true Barrett columnar epithelium, complete with those intestinal transcription factors like CDX2 that we just talked about.
Okay, let's unpack this. It's a tissue undergoing a profound biological identity crisis. The structural blueprint is caught squarely in no man's land. The basal layers look squamous, but the surface layers look columnar, and it's frantically churning out mucins just trying to survive.
That's exactly it.
But wait, let me stop you right here. I'm going to push back on
You
that.
go for it.
We just established biologically that up to 90% of patients have this P16 aberration. And we know CDX2 and TP53 mutations happen before we can visually see the dysplasia.
Yes, they do.
If the molecular evidence is that early and that definitive, why on earth do the 2022 ACG guidelines explicitly state that routine immunohistochemical staining IHC for these exact molecular markers is not currently recommended for clinical diagnostics? Why are we intentionally blinding ourselves to the actual molecular start of the cancer?
It feels counterintuitive, doesn't it? I mean, as surgeons, we want the earliest possible warning system.
Of course we do.
But you have to look at this through the lens of population health and predictive value. There is a massive canyon between the presence of a molecular mutation and the actual clinical utility of that mutation.
How so?
Well, yes, the science is indisputable. The P16 and P53 markers are present early. But if we ordered routine IHC staining on every single standard reflux biopsy, the healthcare system would instantaneously collapse under a wave of massive overdiagnosis.
Because finding the TP53 mutation doesn't actually guarantee that that specific patient's tissue will progress to invasive adenocarcinoma.
Precisely. Remember the concept of molecular memory and dormancy. We would identify tens of thousands of patients with a P16 aberration. But as our epidemiological data will prove later, the vast majority of those patients will never progress to cancer.
Right, they just live with it.
Yeah. If you start labeling every patient with an early mutation as precancerous based on IHC alone, you introduce catastrophic clinical anxiety. You might drive surgeons to perform highly invasive, high-risk interventions like ablations or even resections on tissue that might have just sat dormant, causing absolutely no harm for the patient's entire natural lifespan.
So the test is almost too sensitive.
Exactly. The guidelines require a diagnostic threshold that accurately predicts clinical progression, not just historical cellular irritation.
Okay, so because we cannot safely or efficiently rely on routine molecular IHC to drive our operative algorithms, the entire diagnostic burden falls completely, 100%, onto the shoulders of the histopathologist.
Entirely.
The molecular identity crisis we just outlined has to physically manifest under the microscope as a highly specific, observable continuum of structural collapse. We need visual proof of the dysplasia before we act.
And this places an immense burden of responsibility on the pathologist. They are the gatekeepers to our surgical interventions. When they look at the biopsy, the very first fundamental bifurcation in their decision tree is identifying the specific type of metaplasia.
Right.
They must differentiate gastric metaplasia of the distal esophagus from true intestinal metaplasia.
And for the FRCS candidate, understanding this distinction is paramount because the risk profiles are fundamentally different. The source material is very clear. Gastric metaplasia carries a profoundly lower risk of malignant transformation.
Much lower.
In fact, there is ongoing heavy debate in the literature about whether pure gastric metaplasia, in the absolute absence of any intestinal goblet cells, significantly increases the risk of esophageal adenocarcinoma at all.
Because it lacks the profound genomic instability that characterizes the intestinal phenotype. Intestinal metaplasia is the true high-risk player.
A real threat.
Yeah. It is definitively characterized by the presence of goblet cells. These cells possess the specific genomic hallmarks, the chromosomal instability, that acts as the direct runway for adenocarcinoma.
Once that intestinal metaplasia is confirmed, the pathologist must then meticulously grade the tissue along the dysplasia continuum, and the ACG criteria for this are rigid. Let's walk through exactly what the pathologist is evaluating at the cellular level, starting with the baseline: non-dysplastic Barrett epithelium.
Right. So in the non-dysplastic stage, the tissue has changed to columnar, but it remains structurally respectful. The pathologist will note nuclear enlargement and some stratification where the nuclei start stacking on top of each other, but this activity is strictly confined to the deepest basal glands.
Okay, so it's contained.
Yes. The critical defining feature is that as the cells migrate up the crypt to the surface, they mature. The surface architecture remains orderly and uniform. The cells essentially remember how to behave by the time they reach the top.
But then we move into what is arguably the most frustrating pathological category for any multidisciplinary tumor board: indefinite dysplasia.
Oh, it's the ultimate microscopic gray area. Indefinite for dysplasia is the terminology utilized when the pathologist is looking at severe cellular atypia, but they cannot definitively categorize it as gastric, intestinal, or serrated differentiation.
Why is that?
9 times out of 10, this occurs because of extensive regenerative changes driven by severe, active, ongoing inflammation.
So the tissue is basically on fire from the acid and the neutrophil ROS storm. The cells are rapidly dividing just to replace the dead tissue, and that rapid regeneration causes the nuclei to look wild, enlarged, and hyperchromatic.
Exactly.
The regenerative atypia overlaps so heavily with the criteria for true neoplastic dysplasia that the pathologist simply cannot make an unequivocal call.
And you cannot commit a patient to a lifetime of aggressive surveillance or endoscopic ablation based on an inflammatory artifact.
No, absolutely not.
But once the inflammation is controlled and the pathologist can clearly see true, unequivocal dysplasia, the structural rules change. Let's examine low-grade intestinal dysplasia, or LGD.
Okay, in LGD, the architectural distortion becomes undeniable. The pathologist sees goblet cells with significant enlargement and elongation of the nuclei. You see a marked increase in the density of lymphocytes infiltrating the tissue and a significantly elevated nuclear to cytoplasmic ratio.
The nucleus is expanding.
Right, taking up far too much real estate within the cell.
You also see the nuclear stratification extending further up, involving the basal half of the cellular cytoplasm. However, the absolute key differentiator for LGD, the feature that keeps it low grade, is the containment of the mitotic figures.
For replication.
Yes, the cells are dividing rapidly, yes, but those mitoses are strictly limited to the crypts. You will see very few, if any, atypical mitoses, and the surface epithelium still retains some semblance of organization.
That containment within the crypts is the biological line in the sand. Because the moment we advance to high-grade intestinal dysplasia, HGD, that containment completely shatters.
It's a massive shift.
In HGD, the nuclear stratification is no longer confined to the basal half. It involves the full, complete thickness of the mucosa. The pathologist will describe severe nuclear pleomorphism. The nuclei are all drastically different sizes and highly irregular shapes.
And you see a total loss of nuclear polarity. Normally, nuclei sit nicely at the base of the columnar cell. In HGD, they are scattered randomly throughout the cytoplasm.
Just everywhere.
Yeah. And regarding the mitoses, they have broken out of the crypts. In HGD, you observe active, highly atypical mitosis occurring all the way up on the mucosal surface. The cellular machinery is replicating completely independent of normal biological growth signals. It is an uncontained intraepithelial neoplasm.
Which sets the stage for the final, most critical pathological diagnosis before we start discussing systemic oncology: intramucosal carcinoma. This is the exact moment the structural integrity of the esophageal lining fundamentally fails.
Yes. Intramucosal carcinoma represents the breach of the basement membrane. The neoplastic cells have acquired the ability to secrete Matrix metalloproteineases enzymes like MMP9 that actively digest the type IV collagen of the basement membrane.
They're digesting their way out.
Exactly. Once that membrane dissolves, individual neoplastic cells, having lost all structural connection to the parent crypts, actively invade the lamina propria.
The structural descriptions in the pathology report for this stage are incredibly vivid and chaotic. The pathologist will describe a shitting out of malignant cells. They will see complex anastomosing patterns of irregular, sharply angulated glands burrowing directly into the lamina propria or the muscularis mucosae.
It's very distinct.
You'll see back-to-back glands with absolutely no intervening stroma between them.
It is structural anarchy. But it is vital for the surgeon to remember that in all of these stages, from LGD to HGD to intramucosal carcinoma, the neoplasia is still incredibly superficial. It has not yet invaded the deep submucosa.
Right. It's not just that a localized rebellion is growing. It's that the neoplastic cells are actively synthesizing the molecular tools to dissolve the mortar of the city walls.
That's a perfect analogy.
High-grade dysplasia is the heavily armed rebellion completely occupying the entire city, the full thickness of the mucosa, but they are still trapped within the walls of the basement membrane. Intramucosal carcinoma is the exact moment they dissolve that mortar, breach the wall, and begin sheeting out into the surrounding territory of the lamina propria.
And whether that wall has been breached or not is the single most important piece of information for the operating surgeon.
But hold on, here is the massive, terrifying clinical reality that the sources explicitly highlight. Distinguishing between high-grade dysplasia and early intramucosal carcinoma suffers from a profoundly high degree of interobserver variability, even among experienced pathologists.
Oh, absolutely. It's notoriously difficult.
We are talking about the difference between a highly aggressive local disease and an invasive cancer that has access to the superficial lymphatics within the lamina propria. If the experts staring through the microscope cannot reliably agree on whether the basement membrane has been enzymatically dissolved, how can a senior surgeon make a definitive, life-altering operative plan? Are we just flipping a coin on a resection?
You are hitting on the exact reason why the 2022 ACG guidelines are structured with mandatory fail-safes. The ACG recognizes this interobserver variability not as a minor academic debate, but as a profound system-wide clinical vulnerability.
So what's the fail-safe?
Well, because the distinction between HGD and intramucosal carcinoma fundamentally alters the entire surgical algorithm, dictating whether you perform a mucosal ablation or a deeply invasive submucosal dissection. The guidelines mandate that any initial diagnosis of dysplasia must be independently confirmed by a second, highly specialized expert gastrointestinal pathologist.
So you literally cannot proceed with an operative plan on a single read.
Never. The risk of overtreating HGD with a morbid surgery or dangerously undertreating an intramucosal carcinoma with a superficial ablation is simply too high.
You require expert consensus.
Exactly. The anatomical boundary between the basement membrane and the lamina propria might be microscopically thin, but clinically it is massive. The moment those cells enter the lamina propria, they theoretically have access to the mucosal lymphatic channels. The risk of occult lymph node metastasis, while still very low in intramucosal disease compared to submucosal disease, is no longer zero. The entire risk profile shifts.
Understanding the lethal metastatic potential of that microscopic invasion really underscores why our screening protocols have to be so incredibly aggressive. We absolutely cannot afford to wait until a patient presents to the clinic complaining of dysphagia or unintentional weight loss.
By then, it's too late.
Right. By the time symptoms of cancer appear, the lamina propria was breached years ago, and you are likely dealing with advanced node-positive disease. We have to identify the at-risk patient while the disease is still trapped within the mucosal walls.
Which brings us directly to the epidemiology, the specific compounding risk profiles, and the precise matrix the 2022 ACG guidelines use to cast the screening net. We need to know exactly who is harboring this biological time bomb.
Let's analyze the raw prevalence data, starting with the baseline. If you take the general unselected population, the prevalence of Barrett esophagus is extremely low, only 0.8%. Less than 1%.
But watch how aggressively those numbers compound the moment we introduce specific physiological risk factors. In a cohort of patients suffering from chronic GERD, that prevalence immediately jumps from 0.8% to 3%.
A huge jump.
And if the patient has chronic GERD plus just one other recognized demographic risk factor, the prevalence spikes to 12.2%. And if they have a family history, a first-degree relative with Barrett esophagus or esophageal adenocarcinoma, the prevalence leaps all the way to a staggering 23.4%.
The math here is incredibly linear and predictable. The source text states that the prevalence of Barrett esophagus increases by a 1.2% linear progression for every single additional risk factor present in the patient.
And we must dissect exactly what those specific demographic risk factors are, because they are not arbitrary. They are deeply tied to the pathophysiology of the disease. First, there is a massive, undeniable gender disparity.
Men are at higher risk.
Yes. Barrett esophagus is significantly more common in men, presenting at a ratio of roughly 2.1 compared to women. But the truly shocking statistic is the progression to cancer. When we look at who actually develops esophageal adenocarcinoma, the male-to-female ratio explodes to 9.1.
A 9.1 ratio for cancer progression implies a massive underlying biological mechanism. The literature heavily debates this, right? Are circulating estrogens acting as a protective anti-inflammatory agent in women? Or is it related to the different patterns of fat deposition?
It's likely a combination.
Which brings us to the next risk factor, central obesity. We aren't just talking about high BMI. We are specifically talking about visceral central adiposity.
Central obesity is a dual-threat risk factor. Mechanically, a large volume of visceral fat drastically increases intra-abdominal pressure. This mechanical force directly overcomes the basal resting pressure of the lower esophageal sphincter, physically forcing gastric contents upward and exacerbating the reflux.
That makes sense anatomically.
But it's also a biochemical threat. Visceral fat is highly active endocrine tissue. It secretes high levels of pro-inflammatory adipokines, like leptin, while decreasing protective adiponectin. This creates a systemic pro-inflammatory state that accelerates the metaplastic cascade we discussed earlier.
Alongside male gender and central obesity, the other primary risk factors required for screening include being of non-Hispanic white race, being over the age of 50, and having a past or present history of smoking, which introduces direct inhaled carcinogens into the salivary swallow, baiting the esophagus in toxins.
This specific clustering of risk factors is exactly what informs the new ACG 2022 clinical guidelines for screening. And this is highly testable material for the FRCS. The ACG emphatically does not recommend screening every single patient who walks into primary care with a bottle of antacids complaining of heartburn.
So it's the rule.
The specific mandated rule is that screening endoscopy is recommended only for patients with chronic symptoms of GUD who also possess at least 3 of those additional risk factors.
It's essentially a biological combination lock for the endoscopist. Chronic GUD is the absolute mandatory first number you must dial.
Oh.
But the lock will not turn. The criteria for invasive screening EGD is not met until you hear 3 more distinct clicks.
I like that.
GERD plus age over 50 click, plus central obesity click, plus a smoking history click. Once you have GERD plus 3, the threshold is crossed, the trapdoor opens, and you must scope that patient to look for the salmon-colored mucosa.
GERD plus 3 is the exact heuristic clinicians need to memorize. But diagnosing the Barrett esophagus is just the surveillance baseline. The statistic that keeps upper GI surgeons awake at night is the rate of progression to esophageal adenocarcinoma. We know the overall incidence of GERD, Barrett's, and adenocarcinoma has been rising sharply over the last 3 to 5 decades.
Though to be analytically fair, the source text does point out that a portion of that incidence spike is essentially a diagnostic artifact. We have better high-definition scopes, and we are performing millions more endoscopies globally than we did in 1980. We're looking more aggressively, so naturally, we are finding more disease.
That's true. Ascertainment bias definitely plays a role. However, the true progression statistics are what dictate our surgical urgency. Let's look at the absolute annual risk of developing adenocarcinoma, stratified by the pathologist's dysplasia grade.
Okay.
For patients with strictly non-dysplastic Barrett esophagus, the risk is incredibly low. We are talking about an absolute annual risk of 0.1% to 0.5% per year.
Which justifies a very relaxed surveillance interval.
Yeah.
But if the pathologist confirms high-grade dysplasia HGD, the risk profile becomes genuinely terrifying. The annual risk of progression to cancer for HGD is listed at 23% to 60% per year.
It's an imminent threat.
That is an imminent life-threatening crisis. But then, we have the data for low-grade dysplasia LGD. The source explicitly lists the annual progression risk for LGD as a highly variable 1% to 43% per year.
And right there is the most dangerous statistical gray area in the entire management algorithm.
Wait, let's stop and really look at that gap, because for a senior clinician making a decision, that is an absolute nightmare. A 1% risk versus a 43% risk is an unbridgeable statistical chasm.
It's huge.
If a patient is sitting at a 1% annual risk, you can comfortably put them on a PPI and scope them next year. If they're sitting at a 43% risk, they have essentially a coin flip's chance of developing cancer in the next 12 months, and you need to bring them into the theater for ablation tomorrow. How does the 2022 ACG guideline expect a surgeon to manage a single pathological category with that much inherent variance? We are either massively overtreating the 1% with unnecessary ablations, or we are dangerously, lethally undertreating the 43%.
This is exactly where purely relying on a piece of paper from pathology fails, and where advanced endoscopic clinical judgment must take over. You cannot just read the words low-grade dysplasia on a chart and apply a blanket algorithm.
So what do you do?
The expert consensus dictates that you must stratify that variability by meticulously evaluating the macroscopic concurrent factors present during the endoscopy. The sheer variance from 1% to 43% is driven almost entirely by the presence or absence of an endoscopic mucosal abnormality.
So the visual topography of the tissue dictates the true biological threat level.
Precisely. If the endoscopist reports that the LGD is completely flat and only found focally in one single biopsy out of 16, that patient's true risk is heavily weighted toward the 1% baseline.
Okay.
However, if the endoscopy reveals diffuse LGD that is intimately associated with a visible mucosal nodule, an ulcerated depression, or an elevated mass, that patient's risk profile violently shifts toward the 43% end of the spectrum. The macroscopic architecture predicts the molecular regression.
Which means the standard quick 5-minute look-and-see endoscopy is utterly insufficient and genuinely dangerous for these patients. Because identifying a subtle 3mm nodular depression in a sea of inflamed Barrett mucosa is incredibly difficult. To resolve that statistical ambiguity, the endoscopist has to deploy highly regimented advanced diagnostic protocols to meticulously map every square millimeter of the disease.
You are transitioning the procedure from a passive observation into an active, highly structured diagnostic mapping exercise. The absolute gold standard diagnostic modality remains the high-definition esophagogastroduodenoscopy, the EGD, combined with physical forceps biopsies for histological confirmation. But the methodology of how, where, and how many biopsies you take is strictly regulated.
The guidelines divide the biopsy protocol based entirely on the measured length of the Barrett segment. For shorter segments, the ACG recommends a minimum threshold of 8 biopsies to maximize the statistical probability of capturing focal dysplasia. This specifically means taking 2 biopsies from each of the 4 quadrants, spaced at 2-centimeter intervals.
That's the baseline for short segments. But if you are dealing with a segment that is greater than 4 centimeters in length, the baseline is thrown out, and you must rigidly adhere to the Seattle Protocol.
The famous Seattle Protocol.
Yes, the Seattle Protocol dictates a very specific sequence. First, the endoscopist must actively search for and biopsy any visible mucosal lesions, nodules, ulcers, plaques. You target the macroscopic threats first.
Yep.
Only after the targeted biopsies are complete do you begin the random mapping, taking 4 quadrant biopsies every 1 to 2 centimeters for the entire continuous length of the Barrett mucosa.
Let's truly conceptualize the physiological reality of the Seattle Protocol for the endoscopist. If you have a patient with an 8-centimeter Barrett segment, taking 4 quadrant biopsies every 1 centimeter means you are taking 32 individual blind biopsies, plus the targeted ones.
Just a lot of bites.
You are essentially playing a microscopic high-stakes game of battleship in the dark. You are firing your biopsy forceps blindly into a massive grid of tissue, hoping against hope that your 2-millimeter forceps jaw happens to land on the exact 3-millimeter coordinates where a highly focal nest of high-grade dysplasia is hiding. It is mathematically terrifying.
It is incredibly tedious. It massively prolongs the sedation time for the patient, and it requires intense, unwavering concentration from the endoscopist. And despite all that effort, it's notoriously prone to sampling error.
Because it's blind.
Right. You can easily have a highly aggressive focus of intramucosal carcinoma sitting right between your 1-centimeter biopsy intervals, completely undetected. This inherent mathematical flaw in blind forceps biopsies is exactly what is driving the massive technological push to illuminate the topography of the mucosa.
We need better ways to see the enemy. The source material outlines several of these critical technological advances. Baseline high-definition white light is no longer considered advanced. It's the bare minimum. We now utilize chromoendoscopy.
Yes, vital tool.
This can be physical chromoendoscopy, using a spray catheter to apply topical acetic acid. The acid transiently breaks the disulfide bonds in the superficial mucus layer, abruptly highlighting the mucosal pit patterns and making subtle nodularity pop out visually.
Or you can utilize optical electronic chromonoscopy, which is built directly into the modern scope processors. The most heavily validated system mentioned in the texts is narrowband imaging, or NBI.
How does NBI work?
Well, NBI utilizes specific optical filters to restrict the emittive light to exact wavelengths, specifically 415 nanometers and 540 nanometers. These exact wavelengths are heavily absorbed by hemoglobin. Therefore, NBI acts as an incredible optical contrast agent, drastically highlighting the superficial capillary networks.
Because the tumors need blood.
Exactly. Since neoplastic tissue like HGD requires heavy angiogenesis to survive, NBI makes those dysplastic hypervascular areas light up dark brown against the background tissue, directing the endoscopist exactly where to biopsy.
And the data confirms this. Studies explicitly show that targeted biopsies using NBI demonstrate endoscopically visible lesions in dysplasia with a significantly higher yield than just blindly utilizing the Seattle protocol.
The numbers don't lie.
But the technology goes even further, moving away from the optical and into the physical and computational realms. The text discusses wide-area transepithelial sampling, or Watts 3D. Instead of a tiny forceps bite, Watts uses a stiff brush to aggressively abrade a massive surface area of the Barrett epithelium, capturing cells from a much wider field. Those cells are then analyzed by a neural network computer system to flag the most atypical cells for the pathologist.
We are even seeing the deployment of real-time artificial intelligence during the endoscopy. Systems currently being evaluated in major centers in the US and the Netherlands use machine learning algorithms trained on millions of images of dysplasia to draw a bounding box on the live video feed, explicitly telling the endoscopist, biopsy right here, this tissue architecture is statistically abnormal.
It's like having an expert looking over your shoulder.
Exactly. Furthermore, we are developing alternatives to bypass the high cost and cardiovascular risk of sedated endoscopy entirely.
Like unsedated transnasal endoscopy using ultra-thin scopes.
Exactly. And the most fascinating development is the swallowable capsule sponges, like the Cytus sponge. The patient swallows a capsule on a string, the capsule dissolves in the stomach, releasing a spherical sponge.
It sounds uncomfortable but effective.
It is. As the nurse pulls the sponge back up through the esophagus, it blindly collects millions of cells along the entire length. Those cells are then sent for molecular analysis, looking for highly specific biomarkers like methylated DNA markers or trefoil factor 3-TFF3, which is a specific marker for intestinal metaplasia. It's a non-endoscopic screening tool with massive population-level potential.
Okay, but hold on. Let me interrupt with a critical clinical reality check regarding the guidelines here.
All right.
We just stated that NBI-targeted biopsies, Watts 3D brushing, and AI systems are proven in recent studies to yield a significantly better detection rate of dysplasia than blindly firing forceps into the dark with the Seattle protocol.
They are better, yes.
If the new technology is undeniably statistically better at finding the cancer, why haven't these modalities completely replaced the old ACG and Seattle protocols in the core guidelines? The source text explicitly admits that NBI and Watts have not yet been incorporated into current ACG guidelines as mandatory replacements. Why are we officially holding on to an inferior blind 40-year-old protocol when we have optical and AI systems that can clearly see the disease?
It is a phenomenal question that strikes at the very heart of how international surgical and medical guidelines are actually formulated. It is not just about what works best in the hands of a world-renowned expert at an academic quaternary care center.
Right.
It is about the incredibly rigorous evidentiary threshold required for ACG guideline inclusion, which focuses on global standardization and reproducibility. Yes, an expert using NBI will have a higher detection rate, but the guidelines must apply safely and universally to every general gastroenterologist and surgeon in every community hospital around the world.
So it's an issue of skill translation and broad validation.
Exactly. The ACG has to balance the cutting-edge sensitivity of AI and NBI against the proven, globally standardized reproducibility of the physical Seattle protocol. Before the ACG can officially mandate NBI or Watts as the primary medico-legal standard of care, effectively replacing the forceps, they require massive, multi-center, randomized controlled trial data.
They need bulletproof evidence.
Yes, demonstrating not just that we find more lesions, but that finding those lesions translates to a uniform mortality benefit across all operator skill levels. Until that overwhelming threshold of evidence is met, the highly reproducible, albeit tedious, forceps protocol remains the unshakable legal and clinical standard.
That makes perfect sense from a systems-level perspective. Standardization is the bedrock of safe surgical practice. And speaking of the absolute necessity of standardization, once the biopsies are taken, we must definitively map the macroscopic extent of the disease using a universal language. You cannot just write a lot of Barrett's in the operative note.
Definitely not.
The entire global community utilizes the Prague criteria.
The Prague criteria ensures that a surgeon reviewing a scope report in London understands exactly what the endoscopist saw in New York. It is purely an anatomical measurement system, utilizing two specific metrics based on the centimeter markings on the endoscope, C and M.
Let's precisely define the landmarks for the FRCS candidate. The measurements are taken relative to the top of the gastric mucosal folds, assuming the hiatal hernia has been reduced, and you are at the true gastroesophageal junction. C's stands for the circumferential length of the Barrett epithelium. How far up the esophagus does the solid, unbroken ring of metaplasia extend?
And M stands for the maximal extent of the Barrett mucosa. The critical nuance for the M criterion is that it specifically includes any non-circumferential finger-like projections or tongues of Barrett epithelium that extend proximally up the esophageal wall beyond the main circumferential segment.
However, there is a very specific, highly testable exclusion rule in the Prague criteria. Isolated, scattered islands of intestinal metaplasia that are completely separated by normal squamous tissue from the main contiguous segment are explicitly excluded from both the C and M measurements. You do not count the islands.
Let's run a clinical scenario. The endoscopist reduces the hiatus and identifies the top of the gastric folds at 40 centimeters from the incisors. They see a solid 360-degree circumferential tube of salmon-colored mucosa extending up to 35 centimeters from the incisors.
Okay, got it.
From that point, there is a single distinct tum of Barrett tissue streaking up the posterior wall, ending at 32 centimeters from the incisors. They also see a tiny isolated island of metaplasia at 30 centimeters.
Let's do the math. The circumferential segment is from 40 to 35, which is 5 centimeters long. The maximal extent goes all the way up the tongue to 32, which is 8 centimeters from the gastric folds. We completely ignore the isolated island at 30. Therefore, the standardized universal classification for this patient's disease is C5M8.
Precisely. C5M8 instantly paints an exact, universally understood structural picture. And once that map is drawn, and the biopsies have been independently confirmed by two expert pathologists, the clinical paradigm abruptly shifts.
The mapping phase is over.
Yes. We move directly into definitive treatment. For the modern upper GI surgeon, this requires a total mastery of the algorithms for endoscopic eradication therapy, or EET.
And this represents a massive historical shift. Because 20 years ago, finding high-grade dysplasia meant immediately prepping the patient for a highly morbid esophagectomy. But before we get to the physics of ablation or resection, we have to establish the medical foundation. Every single patient diagnosed with Barrett esophagus, regardless of their dysplasia grade, requires rigorous, long-term proton pump inhibitor PPI therapy.
Absolutely non-negotiable.
And the guidelines are explicit. They require this PPI therapy regardless of the severity of their perceived reflux symptoms. Even if they feel totally fine, they take the pill.
This is a critical point of patient education. The PPI is no longer being prescribed purely for symptom control. It is being prescribed as a definitive, long-term chemopreventative agent.
To stop the cascade.
Yes. The clinical evidence strongly demonstrates that profound continuous acid suppression significantly reduces the production of reactive oxygen species, halts the inflammatory cytokine storm we discussed, and fundamentally reduces the statistical risk of progression to neoplastic disease compared to utilizing no treatment or weaker H2 receptor antagonists.
Once that chemopreventive baseline is established, the management algorithm branches aggressively based on the histology. If the patient has completely non-dysplastic Barrett esophagus, the strategy is watch and wait. If the measured segment is less than 3 centimeters, we repeat the EGD surveillance every 3 years. If the segment is 3 centimeters or greater, demonstrating a larger surface area of risk, we actually extend the interval to every 5 years, recognizing the slow biological progression of non-dysplastic tissue.
But what about that problematic category we discussed earlier? What is the strict protocol if the pathologist diagnoses indefinite dysplasia? You can't ignore it, but you can't ablate it.
For indefinite dysplasia, the guidelines dictate a highly specific repeat endoscopy in exactly 6 months. But you do not just wait 6 months. You must actively optimize their acid suppression. The patient is mandated to take twice-daily PPI therapy, and the pharmacology requires the doses to be taken exactly 30 to 45 minutes before a meal.
Timing is everything.
Right. This timing is critical to ensure peak serum concentration of the drug exactly when the millions of parietal cell proton pumps are actively stimulated by the food bolus. You maximize the acid suppression to heal the inflammatory artifacts, so when you biopsy again in 6 months, the pathologist can clearly see if true dysplasia exists beneath the smoke.
That is the management for uncertainty. But if the repeat biopsies or the initial biopsies return a definitive diagnosis of flat low-grade dysplasia or flat high-grade dysplasia, the era of surveillance and waiting is instantly terminated. The absolute preferred treatment modality in the 2022 guidelines is endoscopic eradication therapy.
And we must emphasize how profoundly this EET paradigm has altered surgical training and patient survival. Historically, a diagnosis of high-grade dysplasia or early T1A intramucosal adenocarcinoma often resulted in the surgeon performing a radical esophagectomy. Now, let's be clear about what that entails. You are opening the chest and the abdomen, mobilizing the stomach, physically resecting the esophagus, completely sacrificing the vagus nerves, pulling the gastric conduit up into the chest or neck, and creating an anastomosis.
The physiological devastation of an esophagectomy is immense. It carries an incredibly high risk of perioperative morbidity. You are looking at devastating complications like anastomotic leaks, devastating mediastinitis, gastric conduit ischemia, severe post-vagotomy dumping syndrome, and a non-trivial operative mortality rate, especially in elderly comorbid patients.
Because of that massive physiological toll, the 2022 guidelines state that esophagectomy is strictly no longer the preferred initial approach for flat HGD or early intramucosal adenocarcinoma. Radical surgical resection is now reserved exclusively for cases presenting with definitively poor prognostic factors.
It's the last resort now.
Right. We are talking about tumors demonstrating lymphovascular invasion on biopsy, poorly differentiated tumor grades, or crucially, tumors that have actively invaded beyond the muscularis mucosae and deep into the submucosa T1B lesions.
If the disease is superficial to the submucosa, we deploy ET. ET is not a single tool. It is a comprehensive strategy utilizing various advanced endoscopic modalities to physically destroy or resect the neoplastic tissue from the inside out, completely preserving the structural integrity of the esophageal tube.
And for broad areas of flat dysplasia, what's the go-to?
For flat dysplasia, the absolute workhorse of the endoscopist is radiofrequency ablation, or RFA.
RFA is a marvel of biophysics. The endoscopist introduces a specialized catheter equipped with a tightly spaced bipolar electrode array. This array is applied directly to the Barrett mucosa. When activated, it delivers highly controlled radiofrequency energy, specifically calibrated to deliver roughly 10 to 12 joules per square centimeter. This energy physically vaporizes the intracellular water, causing instantaneous coagulative necrosis of the tissue.
But the true genius of RFA is its depth control. The bipolar array is engineered to ablate to a precise depth of approximately 500 to 1,000 microns.
Just enough to hit the target.
Exactly. This ensures complete destruction of the metaplastic mucosal crypts, but crucially, it prevents the thermal injury from penetrating deep into the muscularis propria. Sparing the deep muscle layer is vital to prevent the esophagus from structurally scarring and closing off.
The devices are modular too. You can use a balloon-based catheter for a full 360 degrees circumferential ablation of the entire lumen, or focal paddle-style catheters to ablate 90 degrees or 180 degrees of specific tongues or islands. You physically burn the aberrant mucosa away, and because the patient is on massive doses of PPIs, the tissue regenerates in a non-acidic environment, allowing normal, healthy squamous epithelium to repopulate the area.
It is highly effective, achieving eradication in the vast majority of patients, but it is a thermal burn inside the chest, so it is not without severe side effects.
Gotta hurt.
Oh, patients routinely experience agonizing retrosternal chest pain and severe odynophagia pain with swallowing for up to 14 days post-procedure. And despite the depth control, more serious complications do occur, including stricture formation requiring serial balloon dilations, aspiration events, bleeding, and potentially devastating mucosal lacerations or deep perforations.
If a patient's anatomy or specific disease pattern makes RFA unsuitable, the endoscopist can utilize cryotherapy. This relies on thermodynamics rather than radiofrequency. The endoscopist sprays liquid nitrogen or highly compressed nitrous oxide directly onto the tissue or applies it via a supercooled balloon.
Flash freezing.
Exactly. This flash freezes the mucosa to minus 190 degrees Celsius, inducing immediate intracellular ice crystal formation. The ice physically ruptures the cell membranes, and the subsequent thawing causes devastating ischemic necrosis of the microvasculature. The metaplastic tissue simply dies and sloughs off.
There is also hybrid argon plasma coagulation, or APC. This uses ionized argon gas to conduct a high-frequency electrical current to the tissue without physical contact. It is excellent for precisely targeting tiny, persistent, isolated islands of intestinal metaplasia. But the literature explicitly warns that utilizing APC for broad circumferential ablation carries an unacceptably high rate of severe, intractable stricture formation.
So RFA, cryo, and APC are the ablative weapons for flat, visually smooth dysplasia. But what happens if, during your meticulous Seattle protocol mapping, you identify a visible mucosal nodule, an ulceration, or a raised mass? You absolutely cannot just apply an RFA paddle and burn a mass.
Never. Burning a mass is a catastrophic oncological error. If there is a nodule, it implies a localized aggregation of actively dividing cells. It might be harboring an invasive cancer deep within its core.
But if you ablate it?
If you ablate it, you destroy the tissue, meaning the pathologist can never analyze it to determine the depth of invasion. You might leave highly aggressive, invasive cancer cells alive deep in the submucosa, hidden beneath a layer of regenerated squamous tissue. If there is a nodule, you must resect it whole.
This mandates the transition from ablation to endoscopic resection techniques. Endoscopic mucosal resection, or EMR, and endoscopic submucosal dissection, or ESD. EMR is generally the preferred modality for smaller, focal, and relatively superficial nodular neoplasia. The endoscopist injects fluid into the submucosal space to lift the lesion away from the deep muscle layer, deploys a wire snare around the base of the nodule, and uses electrocautery to amputate it.
EMR is fast and effective for small lesions. But if the nodule is extensive, bulky, or most importantly, if the macroscopic appearance suggests the cancer may have already invaded into the submucosa T1b disease, EMR is insufficient. You cannot risk taking the tumor out in multiple fragmented pieces because the pathologist will not be able to evaluate the deep and lateral margins.
They need it in one piece.
Exactly. This requires the technical mastery of endoscopic submucosal dissection, or ESD.
ESD is arguably the most technically demanding procedure in advanced endoscopy. You inject a viscous fluid, like hyaluronic acid, deep into the submucosa, creating a massive fluid cushion that physically separates the tumor-bearing mucosa from the underlying muscularis propria. Then, utilizing microscopic, specialized electrosurgical knives, the endoscopist meticulously, millimeter by millimeter, dissects the delicate submucosal connective tissue fibers underneath the entire lesion.
It allows for the en bloc resection removal in one single, continuous, perfect piece of massive lesions, regardless of their size. It provides the pathologist with a pristine, unfragmented specimen to definitively prove that the deep margins are clear of cancer and to accurately measure if the submucosal invasion is superficial or deep.
The overarching strategy for advanced disease is incredibly coordinated. I like to conceptualize combining an en bloc resection technique like ESD with subsequent follow-up RFA as a highly orchestrated, two-phased military campaign.
That's exactly how you have to view it.
First, you utilize the precision of ESD as a targeted surgical strike to completely excise the primary enemy command center, the visible nodular mass. You remove it entirely for deep pathological intelligence gathering. Once you know the margins are clear and the deep muscle is safe, you deploy RFA to blanket bond the surrounding territory. You ablate the remaining, visually flat Barrett mucosa to ensure absolutely no residual metaplastic cells are left behind to regenerate a new threat.
That is exactly the modern paradigm. Resect the visible threat, then ablate the field. And the ultimate singular goal of this intense multi-stage campaign is to achieve a state of CEN complete eradication of intestinal metaplasia. You want the pathologist to confirm that there is absolutely zero evidence of Barrett tissue remaining anywhere in the esophagus.
However, achieving CIM does not mean the patient is cured and discharged from the clinic. The biological propensity for recurrence remains incredibly high. Post-CM surveillance is arguably as rigorous as the initial treatment. The guidelines mandate taking random biopsies from the entire neosquamous epithelium, but you must aggressively target the gastric cardia and the distal 2 centimeters of the esophagus, just above the Z-line.
That's the danger zone.
Exactly. This junction is exactly where recurrent intestinal metaplasia loves to hide.
The specific intervals for this post-CIM surveillance are governed entirely by the absolute worst histological grade the patient had before the eradication process began. The risk remains tied to their historical baseline.
So they don't get a clean slate.
No, the history matters. If the patient originally presented with LGD, achieved CIM, and is stable, you repeat the endoscopy at 1 year post-CIM. Then again at 3 years post-CIM. If they remain completely clean, they can return to standard, long-interval, non-dysplastic surveillance.
But if their original diagnosis was high-grade dysplasia or early intramucosal adenocarcinoma, the clinical leash is incredibly tight. You must perform rigorous surveillance endoscopies at 3 months, 6 months, and 12 months following the achievement of CEIM. And even if there is absolutely no evidence of recurrence after that grueling first year, you are still required to scope them annually for the rest of their natural lives. The surveillance never stops.
And we must address the reality of refractory disease. What happens when endoscopic eradication therapy simply fails? What if, despite multiple rounds of high-dose RFA, the metaplasia stubbornly persists, regenerating again and again?
It's a tough spot.
The management options escalate rapidly. You first assume the acid suppression is failing, you maximize the PPI dose, or you transition the patient to a newer, more potent class of drugs called potassium-competitive acid blockers, or PCABs.
How do those work?
Well, PCABs work by directly and reversibly binding the potassium binding site of the H plus K plus ATPase enzyme, providing a much faster and more profound acid suppression than PPIs. Though the guidelines note that while theoretically superior, PCABs still require extensive, dedicated clinical trials specifically for refractory Barrett's.
If pharmacological suppression fails, you must consider mechanical intervention. You might send the patient to the surgical theater for a laparoscopic anti-reflux procedure like a Nissen fundoplication to physically rebuild the lower esophageal sphincter and mechanically stop the refluxate from ever reaching the ablation zone. Or, if the patient refuses surgery, you simply commit to serial, repeated, endless EET sessions, hoping to eventually exhaust the regenerative capacity of metaplasia.
But wait, let's inject a real-world, high-anxiety clinical scenario into this perfectly structured algorithm.
Let's hear it.
We discussed earlier that the guidelines strongly state esophagectomy has immense morbidity and should be avoided in favor of endoscopic ESD for early cancer. But what if your pathologist comes back after an en bloc ESD resection and states, margins are clear, but this was a T1B lesion. The cancer had invaded deeply into the submucosa.
Oh boy.
The guidelines say an esophagectomy carries high mortality, but isn't leaving a patient who has a proven, deeply invasive submucosal cancer, a cancer that has direct access to the rich lymphatic network of the deep submucosa, to be managed purely by local endoscopic surveillance, just as lethally risky for their long-term oncological survival. Aren't we intentionally undertreating an invasive cancer simply to avoid a surgical complication?
That is the ultimate terrifying surgical tightrope that every upper GI multidisciplinary team walks every week. It's a brutal calculation. You are directly weighing the incredible margin-clearing local precision of modern ESD against the sheer devastating physiological trauma of an esophagectomy.
And the deciding factor almost always comes down to patient physiology, not just tumor biology. An esophagectomy fundamentally, permanently alters a patient's anatomy, their mechanics of eating, and their overall quality of life. It carries significant risks of sepsis, stricture, and mortality.
You have to look at the whole patient.
You absolutely must factor in the patient's age and cardiovascular comorbidities. If you have a 45-year-old marathon runner with a T1B lesion, they go straight to the operating theater for an esophagectomy and a radical lymph node dissection, because they can survive the hit and they need the oncological cure.
But if you are looking at a 78-year-old patient with severe COPD, poorly controlled diabetes, and a history of myocardial infarction.
Exactly. That patient will likely not survive the physiological stress of having their chest open and their stomach mobilized. The immediate perioperative mortality risk of the esophagectomy far outweighs the statistical risk of leaving a potentially micrometastatic lymph node untreated. In those fragile patients, ESD becomes not just a compromise, but the only viable life-saving option. You resect the primary tumor locally from the inside, accept the small risk of occult nodal disease, and spare them the surgical trauma that would likely kill them on the table. It requires immense, nuanced clinical judgment to decide who gets the endoscope and who gets the scalpel.
That dynamic perfectly highlights why esophageal adenocarcinoma is a fundamentally multidisciplinary disease. You need the advanced endoscopist, the specialized pathologist, the foregut surgeon, and the oncologist, perfectly aligned to make these life-or-death judgment calls.
But here is the final crucial reality check. Even if the multidisciplinary team functions perfectly, even if you achieve a massive technical victory attaining CE-IM through flawless ESD reception of a nodule and subsequent total RFA of the flat mucosa, that technical victory is temporary if you do not address the root cause.
The environment.
Yes. The patient's long-term survival and freedom from recurrence rely entirely, 100%, on aggressively managing the underlying physiological environment that initiated the cellular cascade in the very first place.
You can burn away the smoke, but if you don't extinguish the fire, the house will burn down again. We have to discuss deterrence, intense patient education, and the overall prognosis. Because if the toxic acid and bile continue to bathe the newly regenerated squamous tissue, the entire genetic reprogramming cascade just restarts from zero.
Let's start with the objective prognosis, because it is crucial for managing patient anxiety. A diagnosis of Barrett esophagus sounds like a death sentence to a patient. But the source material highlights a profoundly reassuring statistical reality. Greater than 95% of patients diagnosed with Barrett esophagus will never, ever develop a malignancy.
That's a huge relief.
It is. If early detection protocols are followed, regular surveillance is maintained, and timely endoscopic interventions are deployed when dysplasia arises, the overall prognosis is highly favorable. In fact, normal average life expectancy should be anticipated, provided adenocarcinoma is successfully avoided.
However, maintaining the average life expectancy is not passive. It requires intense, unwavering patient compliance with major lifestyle modifications. Patient education is the absolute final line of defense. The text dictates that smoking cessation and aggressive weight loss are not just generic health advice, they're absolute mandates due to their direct, independent pathophysiological links as primary risk factors for esophageal adenocarcinoma. You have to remove the carcinogens and reduce the intra-abdominal pressure.
And then the clinician must enforce the dietary strictures. The patient must fundamentally alter how they fuel their body. They must adopt a strict, low-fat, high-fiber diet. They are explicitly instructed to avoid fried or heavily fatty foods, spicy foods, alcohol, caffeinated beverages, carbonated drinks, chocolate, highly acidic juices, and specifically, tomato sauce.
Let's explain the physiology of why those specific foods are banned, because it's not arbitrary. It all comes down to the basal resting pressure of the lower esophageal sphincter, the LES. Foods high in fat, chocolate, and caffeine actively induce biochemical changes, often mediated through intracellular CAMP or calcium pathways in the smooth muscle. They cause profound, transient relaxations of the LES. They physically open the valve.
It's mechanical failure.
Right, and carbonation physically distends the gastric fundus, forcing the valve open mechanically.
So it's a mechanical and chemical restriction. Furthermore, drastic behavioral changes regarding the mechanics of eating are mandated. The patient must switch to eating multiple small meals throughout the day rather than 2 or 3 massive, dense meals. A large meal causes massive gastric distension, maximizing the pressure against the failing LES.
And perhaps the most critical behavioral intervention of all, they must strictly, unequivocally avoid eating or drinking anything for a minimum of 4 hours before lying down for bedtime. Because when a patient's upright, gravity and secondary esophageal peristalsis work together to clear any reflux acid back into the stomach. When they lie flat, supine, gravity is eliminated.
And then what happens?
If there is food in the stomach stimulating acid production, that highly toxic bile-rich refluxate will simply pool in the distal esophagus for hours, silently burning the tissue while they sleep.
The contrast of our entire discussion today is honestly staggering. I mean, we have spent an hour diving deep into complex intracellular DNA mutations, the loss of tumor suppressor genes, the enzymatic destruction of the basement membrane, mapping the esophageal lumen down to the millimeter, and vaporizing precancerous tissue with liquid nitrogen and high-frequency radio waves.
And yet, after all of that high-tech molecular warfare, the ultimate, final line of defense, preventing the recurrence of a lethal cancer, essentially boils down to you must eat smaller meals, avoid the chocolate, and make absolutely sure you skip the late-night tomato sauce.
It sounds incredibly mundane compared to the biophysics of RFA.
But I have to ask you, biologically, does adopting this low-fat diet, losing weight, and skipping the tomato sauce actually do anything to reverse the cellular metaplasia that has already occurred? If a patient changes their life, do the cells heal? Or is all this lifestyle modification purely palliative, simply designed to stop the initial chemical insult from continuing?
That is the pivotal biological question. It is absolutely crucial for the surgeon to understand that lifestyle modifications, dietary changes, and even maximal dose PPIs are incredibly effective at halting the active inflammatory cytokine cascade. By physically and chemically stopping the refluxate, you stop the distressed squamous cells from continuously releasing interleukin-8 and interleukin-1b. You stop the neutrophil migration, you stop the massive production of reactive oxygen species, you fundamentally quiet the biochemical battlefield.
You stop the active damage. But what about the genetic damage that has already been done? What about the mutations?
And that is the sobering reality. The lifestyle changes, the weight loss, the PPIs, they cannot in any way reverse established genetic mutations.
Right.
Once that P16 clonal aberration has occurred, once the TP53 mutation is permanently locked into the cellular DNA architecture, avoiding chocolate and sleeping on a wedge pillow will not magically repair the tumor suppressor gene. The genetic damage is permanent and irreversible.
So the cells have a molecular memory of the trauma.
Precisely. And that irreversible molecular memory perfectly, starkly illustrates exactly why post-CEIM endoscopic surveillance remains an absolute, non-negotiable lifetime mandate. You can quiet the inflammation. You can use RFA to burn away all the macroscopic visible metaplastic mucosa, but the inherent genetic propensity for replication error might still be lingering in the microscopic background, perhaps in a stem cell niche, just waiting for a single failure in acid suppression to present an opportunity to regenerate.
We can eradicate the visible structural threat, but we cannot erase the molecular history of the disease.
Indeed. We're managing a chronic genetic vulnerability, not just curing an acute burn. And as we wrap up this massive deep dive into the cellular and surgical complexities of Barrett esophagus, I want to leave you, the FRCS candidate, with a final highly provocative forward-looking concept to mull over.
Oh, a look into the future of surgical science.
Exactly. Let's circle all the way back to the beginning of our discussion, to the fierce debate surrounding the true cellular origin of this metaplasia. We discussed the systemic theory, the idea that Barrett's epithelium truly originates from undifferentiated mesenchymal stem cells that are actively migrating all the way from the bone marrow, traveling through the bloodstream to heal the acid burn in the distal esophagus.
Driven by that SDF1-CXCR4 chemokine homing axis we talked about.
Yes, if that theory holds true, and the source of the metaplasia is actually systemic recruitment rather than local mutation, could the future of foregut surgical management eventually bypass the need for massive acid suppression and destructive local tissue ablation entirely?
That would be a fundamental, earth-shattering paradigm shift in gastroenterology.
Imagine a surgical future where, instead of blindly burning the tissue with radiofrequency waves or subjecting frail patients to the massive trauma of cutting out the esophagus, we develop highly targeted, systemic molecular therapies. Drugs designed to specifically blockade the CXCR4 receptors on the bone marrow stem cells or neutralize the SDF1 homing signals secreted by the burned esophagus.
You would essentially jam the communications network.
Exactly. We could effectively cut off the metaplastic cascade at its absolute biological source, preventing the aberrant cells from ever leaving the bone marrow, stopping the disease before it ever has a chance to visually begin. It forces every clinician to step back and ask a profound question. Are all our current, highly advanced endoscopic techniques simply treating the macroscopic symptom of a much deeper, systemic biological response?
That is exactly the kind of provocative, systemic, out-of-the-box thinking that separates a competent surgical registrar from a truly great consultant-level surgeon. And it circles us perfectly right back to our opening thought. The diagnostic and treatment landscape for esophageal metaplasia is not a clean, binary X-ray showing a clearly broken bone. It is an intensely murky, microscopic battlefield. It is heavily reliant on subjective histological interpretation, and it demands an aggressive, multidisciplinary, multimodality approach to physically map, structurally ablate, and chemically suppress a cellular rebellion before it ever breaches the basement membrane.
Well said.
We hope this exhaustive deep dive has provided you with the precise biological mechanisms, the clinical logic, and the advanced surgical insights you need to directly elevate your daily clinical practice and absolutely conquer your higher FRCS exam preparations. Keep questioning the algorithms, keep interrogating the molecular mechanisms beneath the mucosa, and most importantly, keep pushing the status quo of surgical science. We will see you next time.